Today's conversation with Dr. Jeremy Grummet, who is a urologist, covers a lot of ground in terms of the impact of medicine personally. He's very generous in his sharing of his own taking care of himself and then of sharing his own story in more recent years with his colleagues. Jeremy gives us a lovely demonstration of how we can share our personal stories. We can make ourselves a little bit vulnerable for the benefit of ourselves and other people without risking everything, without risking our reputation, which a lot of doctors particularly do worry about, that if they share some of the challenges that they have going on in their life, that that's somehow going to be to their detriment. We talk about the nuance of that. How do you decide who to talk to, and when is it the right time to have support from your GP or other helping professionals? Later on in the conversation, about 3/4 of the way in, we talk quite a lot about prostate cancer and how that's changed over the last 20 years. If you're interested in men's health, this is a great episode to listen to. Jeremy paints a really succinct picture of how the screening is changing and what treatment is available. So if that's of particular interest to you, that's towards the end of our conversation here. Jeremy has some beautiful insights into empathy and the value in doing study and talking to people outside of medicine to develop your own empathy. He also shares some of his own family story and acknowledges the very great value of humour right at the end in medicine. Enjoy this conversation with Associate Professor Jeremy Grummet. Hello and welcome to Recalibrating with me, Sharee Johnson, where you'll hear healthcare professionals and others sharing their stories of recalibrating life when the unexpected happened. Life is full of opportunities to recalibrate with agency, the right mindset, the right resources, and the right community. Today it's my joy to welcome Associate Professor Jeremy Grummet, who works as a urologist and the Director of Urology at the Alfred Hospital in Melbourne. His main field of practice and research is improving safety and precision of the diagnosis and treatment of prostate cancer. He is currently pioneering focal therapy for localised prostate cancer in Australia's public health system. Jeremy has been interested in philosophy and psychology and how they pertain to life as a surgeon. In 2022, he conceived and convened the first Surgeon as Human workshop as part of the Urology Society of Australia and New Zealand's annual Trainee Week, attended by all urology trainees of these two countries. He also appeared as a guest on the Operate with Zen podcast in 2023, sharing his own experiences and the challenges of life as a surgeon. Rather than offering too much in the way of instructional advice, Jeremy believes that the simple but vulnerable act of sharing one's own struggles from a position of leadership can give others permission to join the conversation and open the door to cultural change that he believes the field of surgery urgently needs. Jeremy is married to Madeleine, who is a journalist and entrepreneur, and together they have 4 wonderful daughters. So lucky. We are so lucky to have this time with you, Jeremy. Welcome to Recalibrating with Sharee Johnson.
Thanks a lot, Sharee. It's great to be a part of your podcast series. Thank you.
Oh, yes, well, it's fun being on the podcast, I have to say. So we might say, Jeremy, that you're in the third of your career in medicine. I'd like to give our audience a bit of context. What's it like working in this part of your career? What are you up to?
Yeah, so I'm the Director of Urology at the Alfred. I've been doing that for the last couple of years. I've worked at the Alfred in Melbourne, which is now part of Bayside Health, for the last almost 20 years. And just taken over, as I say, the last couple of years in the leadership role. So I do that part-time. So I'm a VMO, like most of my colleagues. I have a private practice as well. In addition, I do research, have some postgrad students doing Masters of Surgery and so forth in the field of diagnostics and therapeutics for localized prostate cancer. And as you said, I've got 4 daughters as well, 3 of whom are post-school, so they're at uni, and still 1 in year 11. So yeah, it's a busy life. It's also, it's challenging, it's full, it's varied, and occasionally overwhelming.
Yeah. And just for our listeners, VMO is visiting medical officer. So that for people who aren't in Australia, that might be language you're not used to. So how is it different, Jeremy, what you're doing now? You've been involved in research, public, private work for a long time. So how is it different to the earlier part of your career? What do you notice is different from being a junior medical officer to being a senior medical officer in leadership?
Mm. Well, I think I sort of came to that position, not the official position of Director of Urology, but just realizing a few years ago, I suppose, mid 40s, late 40s, that okay, I'm one of the senior people now. You sort of have to. There's no actual milestone per se. You can be a junior consultant for as long as you realize you're junior, and then you really make the realization, okay, I'm an older person now. I've got, let's say, random figure, a decade of experience under my belt. So actually, I'm an elder, if you like, in the profession, and so I've got a bank of lived experience that I can actually not only inform my own practice and life, but can share with others and hopefully can be helpful in that way. As a junior, you've got your own lived experience, but it's much more difficult to think about yourself, I think, as a leader when you're still very much learning the profession itself. Yeah, there is a real transition, but as I say, it's not a clear demarcation. It's just it's sort of a growing awareness that you move into a senior kind of role. And probably in some cases, and probably mine as well, it might have been a little bit delayed. I'm the youngest of four brothers in my family, and so being the sort of baby brother, psychologically, I think that sort of makes you feel as if you're always a little bit junior, I think.
Mm.
So switching from that to being senior slash elder slash um, leader can maybe potentially take a bit longer.
Mm. You're having me think about new consultants that we work with in our coaching practice, that first year of being the consultant and having the kind of buck stops with me responsibility.
Hmm.
Sometimes I think those young consultants are shell-shocked that they've been so long waiting for the
Mm.
day when they finally won't have to be assessed or have logbooks signed off, or have somebody else kind of controlling what feels like sometimes controlling their
Mm.
lives, to now being the boss.
Yeah.
Then it's suddenly kind of really landing very heavily on their shoulders that, whoa, the buck stops with me, and that's different now, that I can't turn to look to somebody else. And you kind of learning about consulting with colleagues and how and when you consult with colleagues, and when does that feel like a weakness and when does that feel like a strength?
Mm.
Any reflections on I suppose how you see you're director of a department, you're seeing doctors at all different stages in their career.
Yeah.
What do you notice about those transitions into early consultant, and then, as you described, becoming an elder, starting to realize, oh, hang on, I've got something to offer, and
Mm.
maybe people are looking at me now for wisdom.
Mm. Yeah, exactly. Look, I think you're absolutely right. The junior consultant in the first couple of years, there's a feeling of elation that you've made it. You've got your ticket. You're able to practice. You can be somewhat self-sufficient, but it is somewhat because you are still very much relying on your colleagues for that complex case, the curly one that you're not going to find the answer to in any guidelines, for example. Um, Whereas, yeah, when you are much further down the track, chances are you've actually seen that complex case, or you can use principles from another complex case that you can apply to this one, and so on. Another sort of analogy for the junior consultant, it's a little bit like being on your P plates, and the evidence for that in driving is that that's the most dangerous
Mm.
part, actually, of a driver's time driving. When you're on your L plates, interestingly, the risk of injury or accidents and so forth is actually extremely low because you do have that person sitting right alongside you, giving you supervision and advice, and all of a sudden that's stripped away. So I think, yeah, as a junior consultant, it's super important to not feel isolated. And I experienced this myself in private. I was in a group practice. Obviously, in public, you're part of a unit, and I think those group settings for junior consultants are really helpful. One bit of advice, if you are popping out the end of your training, is to aim to, even if it's not a formal group practice, at least have a set of colleagues that you can turn to when things get tricky, because they will get tricky.
Yeah, I think that's, again, something that every doctor learns, that it will get tricky sometime. I saw a clip this morning on social media of a doctor talking about older doctors are kinder. I don't know if there's any proof for that. That's just somebody's opinion. His proposition was that because they know that it will get tricky and that they've all had an experience of something that's not in their control.
Surgery is a fabulous discipline. It's exciting, it's challenging, it's rewarding, but it is absolutely humbling as well. And so one of the jokes we often have is that you like to think at the end of some operation that's gone beautifully well that you could go around high-fiving the whole team. You just can't, because even if you think you've done things perfectly, you cannot be sure that there won't be some complication, some unexpected side effect that occurs, either while the patient's still in hospital or maybe, down the track. And occasionally that will happen, despite your best efforts, not only from yourself, but the whole team. So yeah, perhaps what you're talking about there is some learned humility.
Which is quite contrary to the stereotype of surgeons in the world, isn't it? That we often think about surgeons being kind of hard ass and having a lot of bottle because of the things that you're doing. You're cutting and breaking and doing things to human bodies that most of us don't ever contemplate. How does that sit with you, that there's this stereotype in the world of surgeons being kind of not very approachable, when actually, as you said, your day-to-day job is giving you lessons in humility all of the time?
So it's really interesting you brought that up, Sharee. I was taking a few little notes down to remind myself of a few things I wanted to hopefully bring up during our chat today, and that's one of them. And this stereotype of surgeon, of sort of being this hard ass, pretty emotionally shut down person who just, walks in and out of the room, giving you very little sort of detail and certainly not a whole lot of emotional nourishment. And yeah, I did want to talk about that because it makes me cast my mind back to our cohort at medical school. So, I think about all the people in my year who went through med school, and obviously some branched out into surgery, some went off to be GPs, some went into be physicians, etc., etc. And when I think about those personalities, I mean, okay, we're at a very different stage of our lives. There was not a single person who I would have predicted would become that type of stereotype of person. And yet, some of us would have developed into that. And so it does make me wonder that, yes, there'll be some personality traits that are probably attracted towards surgery, and that maybe empathy is not high among those traits for those people. But my suspicion is that's actually the minority. And I think that this sort of stereotype, which exists to some extent, is actually more about conditioning. And it may well be that the sort of relentless problem solving after problem solving in a often life and death situation leads to a kind of withdrawal emotionally as a preservation mechanism, a self-protection. And then that sort of makes me think about the different types of empathy that exist. So I just try and imagine if you were emotionally empathetic with every patient that you saw, emotionally, and you were feeling their pain. I personally don't think that's a sustainable approach to practicing medicine. I just think that would be too much. I think where the happy medium sits, rather than just withdrawing completely and ditching empathy, is the concept of cognitive empathy. I think is actually one, from my perspective, where doctors, any healthcare professional might find a sweet spot in practice, because if you can cognitively or mentally understand, know that what your patient is going through and have that, but without feeling it. And I think this is an important distinction. I find myself doing this all the time. If I think about patients who sit across me from on my consulting desk, which is where I am right now, and I try to, well, I understand where they're at. And I feel after 20 years of practice that I've really got a good handle on that. But I very rarely, unless perhaps I'm a bit emotionally churned myself for whatever other reason, I rarely engage my own emotions in theirs. I think if I did, then it would be a very difficult to do that with, and quite frankly, impossible to do that with every patient. And I'm not sure it would necessarily serve the patients as well either. So I know
Yeah.
we've gone down a bit of a rabbit hole there, but
I was thinking that we could spend the whole time just on this topic, couldn't we? And we will keep moving. But I totally agree with you. If you're the most empathic person going around,
mm,
you're meeting every person that you meet with full, skillfully empathic with them. That's a huge
mm,
burden that you're going to carry
mm,
around for the rest of it. You know, joining the person in their difficulty or in their challenge is not enough. We can't stop there. We need to be able to progress beyond there into compassion and action. The science is pretty clear about that now, that the empathic burden comes from being fully empathic and leaving it
mm,
there. That's not enough. And you're drawing a different distinction between cognitive and emotional empathy. And I think that's where we could get into a big conversation. It's a really good framework. It sounds like it's working for you, and I think it's been a very useful framework for a lot of people in psychology as well as in surgery to be able to hold,
mm,
these distinctions between wanting to understand what it's like for the person
mm.
without having to be in that. When you do that, you activate your pain networks neurologically. And so
Yeah.
there's good science to support some of what you're describing. So I wonder, can we go back to thinking about how you developed your empathy? Let's switch tacks a little bit and think about your family and your background. How interesting to be in a household of women now, after growing up in a household of young men with three brothers and four daughters. Can
That's
you
right.
tell us a little bit about your backstory and what happened before you got to medicine?
Yeah, sure. So grew up in a very loving, stable household. Mum and dad, who have both since died in their late 80s. In fact, mum reached 90. Mum was a nurse. Dad was an accountant. As I said before, I was the youngest of four brothers. So it was a very solid, happy family to grow up with. People talk about all sorts of different privileges, whether it's wealth or status and so on. I feel that growing up as a child in a loving, secure family is the highest privilege a human can get. So I certainly feel that. What I would say as being another significant part of my childhood was when I was I would have been about 8 years old when my oldest brother was diagnosed with severe uh, depression, and he has had to battle with that ever since for the rest of his adult life. He was in year 12 at the time when it happened. So that's been a major force in our family. Interestingly, my mother's mother, so my maternal grandmother, also suffered major bouts of depression. And my mum used to describe when she was a girl herself that her own mother would be stuck in bed for months at a time. She also would tell the story of, she would appear in the kitchen one day, this is her mother, and say the clouds lifted.
Mm.
So clearly there's a family predisposition to it. Yeah, that's been a significant part of my upbringing as well. I have 9 years apart from my oldest brother. So I guess in some way I've probably been somewhat protected. I wasn't next in line, if you like, in years as a sibling. And so there was that age gap, particularly in those years when I was still very much a kid and they were all turning into latter teenagers and adults. I was probably fairly protected from that whole initial scenario. But certainly as I've been an adult, I've then transitioned into another carer as well, as my brothers have. Certainly my second brother has very much taken most of the load of that caring, particularly as mum and dad were aging.
Mm. And these experiences, Jeremy, I imagine have informed you as a parent as well as in your medical life.
Yeah, as you said, married Madeleine 27 years ago now, and we had four daughters. So yeah, we flipped the script on the gender, and you know, she also has a significant family history of medical illness. So even when we first met, we shared a lot of our own family stories about that and what it felt like as siblings of people who are suffering major mental illness. And yeah, as a parent, it does inform you, especially as the girls become young women, finishing their teenage years and then going into their 20s. That's when typically major mental illnesses can hit. And so we're aware, we're very much in favour of early intervention. But even early intervention can have its downsides because sometimes you can probably jump the gun and if there's a hint of somebody not being quite right, then you might sort of pull the trigger a bit too quickly, um, and maybe they're just having a flat period that doesn't require
Yeah.
professional help. Maybe they're just young adults finding their way.
I think you're pointing to some really interesting things, though, that, we are all primed for things. We're primed because of whatever's happened in our life and how we understand the world. We're all full of unconscious bias as a result of that. And you're also pointing to just the complexity of life. And I hope our non-doctor listeners are really noticing that, because I think that's another thing that happens, that we come in. Certainly, it was my experience when I came into the health system with my husband with his cancer diagnosis. You're kind of blind to the health professional being a person as well. So we talked already about the stereotype of the surgeon. But I think
Mm.
also, as the patient and the family of the patient, we have our own blindness as well, that, we need the doctor or the nurse or the psychologist, the physio, whoever it is, to focus in on the problem that we've brought into the room.
Yeah.
And we don't want to be too worried about what kind of person they are or what kind of stuff they might have in their background. And health professionals will say all the time, well, that's good. That's not what they should be thinking about. But I think there is a risk from both sides of losing that human connection when we don't acknowledge that that's a real thing that's happening, that people have complex lives. And sometimes the surgeon who might seem a bit disconnected might have some big stuff going on in their other life.
Mm. Yeah, it's an interesting one, isn't it? In the past, there's that real disconnect. There's a very solid sort of professional line that, shouldn't be crossed between patient and doctor. And I think there's legitimacy of that as well. Again, it's just finding the balance between that, where it's all very clinical and scientific, and this is your tumor, and we're going to cut it out, and so on. Versus the other extreme where you really lean right in and you get emotionally attached to patients, and you're worried emotionally about how they're doing and so on. I think again there's a happy medium, and if we don't intentionally manage that, then we can get into strife. We can burnout, classic. So I think burnout is multifactorial, of course, but I suspect that that's one of the major factors at play there.
Yeah, and it's one of the things that I think medical schools are trying to get better at. Sometimes I think we're not developmentally ready at medical school. We need a bit of something to hang it on, and it's actually when we get out into the workforce and we start having some of these experiences that require this real nuance and require skill. It's
Mm.
not just something you can read in a textbook. It's, medicine's a very relational business, and
Mm.
these things that we're talking about here are very fine lines, a little bit this way and a little bit that way, that largely comes from experience and mentorship. Do you feel like you had some
Mm.
good mentors and guides over the last 25 years or so? You've been learning these nuanced skills?
Yeah, it's a really good question, Sharee. The way I would answer that is I think I would say that I've certainly had some good mentorship, although I've probably found most of it outside medicine, in terms of positive experiences. I've got to say, I think there's been, and maybe this is just my experience, but I think that there has been a real lack of that sort of deeper guidance or mentorship about living a surgeon's life. There's plenty of mentorship about, solving clinical problems and complex cases and so forth. But that's very much in its own little clinical category. I think the broader how to live successfully and sustainably as a surgeon, for example, has largely gone missing. Now, having said that, and this is a really important point, you can learn a lot from people who aren't doing such a good job of managing their own surgical lives. Whether you like someone or not, or whether you're a friend or not, you can still learn a ton from observing other people and how they're going about their professional life, how they manage it with their personal life. I wouldn't call that mentorship per se, but maybe you should. It's almost inverse mentorship in a way.
That's a great phrase.
Yeah.
It's something about awareness, isn't it? And you know, the Australian Medical Board requires reflective practice. I think that escapes a lot of people too, that this is a requirement, and we're so busy doing all the practical and technical things that need doing. We know that for reflective practice, we need a space, we need to make space. So I'm wondering how you did that. Were you observing the inverse mentors? How did you? Was there some pattern or process? Was there some way? Did you come home and talk to Madeline? Like, what was the way that you were able to notice or maintain some level of awareness about, that's not what I'm going to do. How am I going to remember that?
Hmm. I mean, yes, Mads and I have lots and lots of conversations about this sort of stuff all the time. We're sort of peas in a pod in terms of that they find that sort of stuff very interesting. It really sort of sparks our curiosity. In terms of sort of deliberately scheduling, I'm not sure I've really done that. It's more been an organic sort of. This is kind of my personality. I'm interested in being, I guess, an observer of human behavior, including my own.
Mm. I
Mm.
know you're a big reader, and because we've had some involvement in the past with some of this work you've been doing about sharing your own story, I know that you have had some outside medicine supporters, people who've helped you when you've needed them. Has
Mm.
that been a part of your uh, what shall we call it? Growing wisdom?
Absolutely. Yeah. So just off the top of my head, there are sort of three sort of people or groups of people that come to mind. So maybe it was a decade ago, I reckon. So I would have been mid-40s. I decided to start seeing a psychologist. And interestingly, I didn't think there was anything wrong. So it wasn't fixing a problem. It was more that I'd got into my head that, we put our car in for a service every, whatever it is, year or two. We see the GP every year or two. We get our teeth checked every year or two. And yet the most important organ of our body, we just fly by the seat of our pants. We don't even bother to get that checked or a tune up, or are we, is it going okay? So I just thought for sort of proactive, preventative type health reasons, I would see a psychologist. And I found that extremely useful. Again, there was no particular issue at the time. As it happened, that turned out to be, and we can talk about this later on, it turned out to be a masterstroke because then stuff did happen, and we can come back to that. But my psychologist, because I'd been proactive, had a baseline on my normal sort of self and function, which I think was probably very useful. So there was psychologist. There's been you, Sharee, as a coach, which I would highly recommend. I think the deliberate scheduling of regular catch-ups to talk about how things are going, outside the day-to-day constant problem solving that we do with our patients is really important. Obviously, you want to be able to do that stuff with family and friends. But in addition, and it's good to be able to do that with somebody who's not coming in with their own identity schema other than a professional perspective. So I found your coaching extremely helpful and would highly recommend that. And then the third group, which was happily completely outside medicine, was something that I just happened to land upon by chance, and the timing happened to be spot on. So this is called the Small Giants Academy, based in Melbourne, and they were running their first ever course. It's an unusual title for a course called Mastery of Business and Empathy. To be honest, there wasn't that much business, I didn't think. It was really, I would say, a leadership course and a sort of a personal exploration course. That just happened to coincide with a whole bunch of COVID lockdowns. And so it was doable because there wasn't nearly as much work or anything else going on in Melbourne with all those lockdowns. So that must have been 2021. That was 3 hours every week on a Thursday night, connecting with this cohort of people. We were the first cohort to go through. And there wasn't a single other medico or health-related person in that cohort. And I found that very refreshing, actually. It was really lovely just to have that opportunity to go really deep, actually, on hearing other people's stories, sharing your own, figuring out a bit better sort of who you were and what you valued in life. Really, the main theme of the whole course was what does a good life look like? How can we create that, not just for ourselves, but for the world? It was a very sort of both inward and outward looking course, which is still running. I felt very fortunate to be a part of that. That really sort of opened things up for me to think much more holistically about things. To answer your question, those outside factors or people have been very important and helpful for me.
And we'll put the Small Giants details in the show notes. I've done a silent retreat with them as well down on the Peninsula. It was fantastic. But you're also having me think about Cheryl Martin, who's been on the podcast previously, who talked about her experience doing the MBA at Melbourne Business School. You did the MBE, she did the MBA, and her experience the same, that no other medical people there, and how much that opened up her perspective and her view of what was possible in the world. And also Dr. Kieran Allen, who's been on the podcast too, talking about this idea of preventative care, that when you have a medical team, when you have a GP, maybe you have a psychologist, maybe you have a social worker, whoever, a chaplain, whoever it is that's your person, that they're ready to go. They know you already. That makes a big difference to the kind of work you can do if things do go pear-shaped at some stage. I wonder if it's a good time to talk about when things went pear-shaped, Jeremy.
Yeah, sure. Yeah.
Tell us your story, what happened?
Yeah, and I might preface it by saying that the idea of sort of telling vulnerable stories is interesting, and it can be scary as well. And I remember first sort of relating this publicly when I was at a urology meeting. It was actually a scientific meeting, but there was an opportunity to bring up this topic and tell this vulnerable story. And I think that the culture that we have currently in medicine is such that I was very fearful. I had no idea what to expect, but I thought, stuff it, I'll do it anyway and see what happens. So I was prepared to take a risk. Basically, what I've talked about publicly before is that I, several years ago, found myself in a situation where, due to a whole lot of stressors, started to develop anxiety, which I don't think I'd ever felt before, or certainly if I had, I certainly hadn't recognized it as being anxiety. And this was very, very different. So I still don't think I had any sort of significant anxiety prior to this. And I would wake up and suddenly feel a sort of clenching in the chest. It wasn't pain, but it was just a clenching type feeling. And it came on about 3 seconds after I'd wake up. So I had relief for about 3 seconds, and then boom, it just hit. And then it would stay with me for most of the morning, and then it would just sort of dissipate throughout the afternoon and would get much better in the evening, and I felt a bit more relaxed in the evening. But this went on night after night for weeks, and then that extended into months. But it was also associated with insomnia. So as I said, towards the end of the day, I'd be feeling okay. I'd look forward to going to bed, to sleep, and I was exhausted, absolutely exhausted. And because I've been feeling anxious for most of the day, and so I'm not only dealing day to day with all the usual professional problems, but I'm also trying to manage this feeling of bodily anxiety as well. So extremely tiring. All you want to do is sleep. And the problem with going to sleep was it was a double-edged sword. You wanted to get that rest, but the problem was I knew that when I woke up, it was going to hit me again. And anyway, this went on for several months, and I thought, this is obviously completely out of the ordinary for me. I'm usually a great sleeper, get my 8 hours, love a good solid sleep, feel refreshed in the morning. This was the complete opposite. And not only that, I would wake up 2 or 3 times a night. Sometimes I'd get back to sleep, sometimes I wouldn't. And then the last time I'd wake up would be 5 a.m., which is way before I normally get up at 6:30 or thereabouts. So I was just losing sleep every single day and couldn't get it back. And then on top of that, my energy was just getting consumed with all this anxiety that I was feeling throughout the day. Now, I managed to keep working throughout all that. I didn't miss, and it sounds like a brag, but it's just the fact that I didn't miss any work during that. Whether that's a good or bad thing, I don't know, but I was able to function still, and do surgery, see patients as per normal. But I certainly wasn't right, and so I turned to books and podcasts and so forth. I was trying all the cognitive tricks to try and figure out think my way out of the situation I was in. I was doing lots of exercise. I was on the exercise bike. I was going to the gym. And I think those things were all helpful. They might have prevented a worsening of the situation, but they did not get me out of it. And so I do remember one night finally calling up my GP, and my GP had been aware of this. So again, this wasn't out of the blue from their perspective. He knew that I'd been feeling anxious. It was more a matter of observing, see if I could sort of come good myself, because it was a relatively short period of time. And I remember thinking as I was ringing him, I can't get myself out of this situation. I'm trying. I feel like I've done all the right things, but it's not actually helping. And I thought, I'm used to being, I guess, a carer of somebody who's had mental problems for decades. Now I need some care, actually. And that was quite a significant sort of moment mentally, I think. And the care in this situation needed medication. I see patients every day, and half of them patients seem to be on some, antidepressant or anti-anxiety medication. So I recognize just how common these issues of anxiety and depression and so forth are in society. And even my own brother had obviously had severe form of this, but for the first time, it was quite a realization, as I suppose, as a doctor, that I was not right myself. I needed help. So anyway, he prescribed medication, and within a few weeks, I had a major turnaround. That horrible feeling of anxiety, which I don't think I can ever forget, left me. It dissipated, I should say. It certainly has left me now, and I just don't get that feeling anymore. I mean, this is many years ago now, but I just don't get that physical clenching, is how I would describe it. That is just so unpleasant and exhausting. That has given me genuine empathy for people who do suffer from anxiety, to the point where I think if you haven't actually felt it, then you just can't know what it feels like. It's just such a distinctive sensation. Anyway, the medication was very helpful. It turned me around. And then I think what I sort of did was use a lot of the reading and listening that I'd been doing in the field of psychology, in the field of meditation as well, in the field of mindfulness, all that stuff, to then not let medication be the foundation in my situation, each to their own. But it meant that I could actually stop taking anything and continue on using non-pharmaceutical means of maintaining good mental health and good physical health. And so I've been very fortunate to be able to do that. But I think in a stressful job like surgery, to assume that you're not going to run into problems from time to time, and we're just talking classic life problems. There might be somebody who you love is not well. It might be interpersonal conflict. There might be financial issues, whatever it might be. there's going to be just life stuff that comes up. And if you add that on top of a very busy and demanding professional life, then you can spiral. And there's no doubt I was not well during that time. I think, I'm now, like we were saying before, I'm in a senior role. I've got a leadership position. I'm a surgeon. And I think it's important that colleagues hear these stories, because I know that a lot of them are either going through or have gone through very, very similar experiences, but have not had the safe space to talk about them, because they're worried about what the repercussions might be. And I get that as well. I mean, I certainly wouldn't want to be talking about this with you if I was right in the middle of such a situation. I'd be too afraid. And also I'd be afraid because I wouldn't know if I was going to get out the other side.
Better, yeah. Yeah.
So I understand the reluctance. It's easy for me to talk about this in retrospect. It's also easy for me to talk about it in the sense that I've got 20 years of career under my belt. So I've got a solid sort of practice and, I guess, professional reputation. And so I can wade into this pond with some confidence, I guess.
Mm. And have the people around you responded positively? You've told this story a few times now. Are people responding positively? Are you seeing more senior doctors share a little bit of their own experience in retrospect? Is that
Not too much other sharing. However, look, I think it's a slow process. I mean, I think the way we go about things is so entrenched that I'm not expecting a sudden, revolution and everyone's talking about how they're feeling and all their vulnerabilities all the time. And also, you wouldn't want to go to that extreme anyway. And again, finding the balance is key. When I did tell this story, state meeting in urology, yeah, people came up to me and it's a bit like men with prostate cancer. Once they get a diagnosis, suddenly all their mates, they realize, have had prostate cancer and they can start talking about it. I see that all the time. And similarly, other surgeons came up to me after the talk and said, oh, yeah, same. Yep, me too, that sort of stuff. So I know from that, and also you don't have to be a genius. I mean, you just look at the statistics. We know that there's high rates of anxiety, depression, substance abuse, and all the other negative things that goes on, not just in surgery, but amongst doctors generally. It's a demanding job.
It's a very demanding job. I think I have so much more compassion for doctors now than I had 13 years ago when I began this journey. You said something I think very important, Jeremy, that at some point during this process when you had anxiety, you said to yourself, it's time for me to have some care now. I hope
Mm,
that particularly the younger health professionals, not just the doctors, can really hear that this pausing and this moment of being able to give yourself permission to recognize to yourself, first of all,
mm,
if you don't notice to yourself, it's hard for anybody else to help you.
mm,
But being able to say to yourself, okay, I need to do something different.
mm,
I wonder who can help me or who can give me some care or
mm,
even I can have a day off today. So
mm.
that I know you said you didn't have any days off, but for some of us, making the space to just
Yeah,
say, I'm going to stay home and go for a long walk today. And
yeah,
the challenge in healthcare is that, particularly in surgery, then if I do that, the list is cancelled and all these other people's lives are disrupted.
correct.
Very difficult moment, a very difficult decision.
Yeah.
But I hope that some of the listeners can be thinking about how far would I have to go? I mean, I meet doctors who've really got their backs against the wall, and
Mm,
and I suppose they're talking to me. Then at least they've made that much space,
yeah.
but really got their backs against the wall, and they are refusing to make any space. And I think it's very hard to create something different, or to change, to break the insomnia, or to find the self-compassion to start responding to the anxiety effectively
Mm,
if you refuse to change anything. So
mm.
that seems like that was an important moment for you to be able to say, I need some care.
It was absolutely a real sort of hinge moment. And it was tricky. Yeah. As a doctor, you are the carer, as a brother, one of his carers, and
I mean, you're
well,
caring in every
that's
direction.
right, husband, everything. That's right. So yeah, to just sort of it is a different mode of being almost when you're so ingrained and conditioned to be that play that role, to then say, okay, am actually not independently coping here and I need some additional help that I can't provide for myself. And it reminds me of one of my favorite sayings, and I'm not exactly sure where it comes from actually. For people like doctors and nurses and other health professionals, we provide a service. So we're in the business of serving our patients' families, serving the community more broadly. And the phrase is, you cannot serve from an empty vessel. And that to me just absolutely nails everything that we're talking about. And to me, at least the way I see what you do, Sharee, with your coaching for doctors, is probably guiding us towards that, and making sure that we are, as doctors, are healthy enough to sustain ourselves so that we can be that service for our patients.
Mm. And the other thing I noticed, Jeremy, is that you were talking about how many people came up and said, "Me too," to you. And so perhaps for those doctors who are out there thinking they need to tell their boss that things are not okay, or that they need to make some change to the days they can work, or whatever it is, that some reassurance that actually the story that we're telling ourselves about how that doctor is perfect, or that doctor's going to think I'm weak, or that colleague's going to judge us somehow, to just make a little bit of space in our mind for the possibility that that person's going to be compassionate and empathic and say, I get this, I understand that, I've been there too, that's also possible. And the story we're telling ourselves about, everybody's going to think I'm weak and none of them are weak, might actually be flawed.
So this is a really interesting one. Yes, I agree. But I think it does come with a caveat. And this is where I worry about, for example, teens or young adults who are like sharing every sort of experience they've ever had online, being vulnerable to an audience of unknown people. And to some extent, I have concerns about, telling my own story there. I limit, aspects of the story because I think there's sharing and there is oversharing.
Totally.
Right. And one of the things in the sort of example you're alluding to there about, talking to a superior, I think you still have to ensure, if possible, that the person you're going to approach is trustworthy, or you have noted by their past behavior that they are trustworthy and supportive. Because there are some people who won't have got to that point in their own life journey of awareness or self-awareness, and they may not understand where you're coming from. So I think if people can choose, who they decide to actually talk about to, that's important rather than just anybody.
Yeah.
Now, again, I've been senior enough to be a little bit more open, but if you're a bit more junior, then it's super important to find people that you can mention this sort of thing to, but also that you can have a sense of trust in them as well.
I love this honesty. I think you're also reminding us that we don't have to talk to the people in the system. And, particularly junior doctors they need people's endorsement and reference and so on to progress into training programs and so on. So the message I'm getting from this part of our conversation is it's important to ask for help or say, I need some help. It doesn't have to be inside the medical system or inside the workplace system. And just to remind people who are listening, you have no obligation to tell your employer what your health issue is. So if you have a health issue that you need to attend to, you don't have any obligation to have to say that. Personally, I think we do have duties of care. We do have a duty of care to assess our risk in our practice. So we're back in the territory of nuance, Jeremy. But hopefully the lesson is that we all need help sometimes, and finding the right person is the skill, perhaps. Sometimes if we're really very unwell, we just need to tell somebody, and it's not about skills. It's about who's the trusted person, who's the person nearby to us. And that can be our sister or our dad or our best friend, as long as we're sharing it with somebody out loud. Did that make a difference for you? Once you said to the GP, once you went and saw your psychologist, did that feel somehow useful or better that somebody knew that you'd said it out loud?
Well, it made it real, that's for sure.
You knew it was real. You were feeling it real every day.
It was, yeah, it was very real. But um, I mean, to be honest, I was desperate. It really was out of desperation. I know you were saying it's important to sort of make space, but I wasn't. I wasn't even. I don't think I was functioning well enough to be that uh, wise. It was literally out of I am so sick of this exhaustion and this constant feeling of anxiety. I've tried my best to wangle my way out of it with various techniques. They haven't worked, so it's time. I need external help, and I knew that that was likely going to be in the form of medication, and that's absolutely fine because sometimes people need medication to help. It was just a first for me. That's all.
Yeah, yeah. And it's a part of the journey. You were doing things without medication. You started taking medication, which gave you access to the things you were trying to do beforehand to make them work. And then you were able to let go of the medication. So the whole picture
Exactly.
is the story.
Mm.
Let's shift our focus now. Thank you so much for sharing your own experience. I agree with you. I think that leaders talking about this stuff makes a big impact on all those who come behind them. Let's talk about prostate cancer. There's some big changes going on in the prostate cancer world, and doctors need to recalibrate. Let's say it like that. That there is a change in attitude to screening. I think you've written recently about how we stage cancer. Can you tell us about what's happening?
That is a big shift. Yep. I'll just open up another part of my brain. Sure.
You can do it.
Yeah, so I have been pretty, I suppose, active in the space. I mean, I've been doing prostate cancer pretty much since my fellowship, which is nearly 20 years ago. Just on that, I actually popped back to Vancouver last month to visit the hospital I did my fellowship at, and so that was a terrific experience going back to Vancouver General. Took the whole family, and that was wonderful. Just yeah, going back after 20 years when we went there, the kids were tiny, and now they're all pretty much grown up. So very interesting and worthwhile thing to do. Anyway, yeah, ever since then, I've been really mainly in the field of prostate cancer. I'm a general urologist, but that's my main area of interest, and it's certainly where all the research has been going on. It's a fascinating field because it is dynamic and changing all the time. And it's so common. That's the other thing. I mean, it's a huge health burden, prostate cancer, and we need to manage it way better than we do. When I was a registrar, one of the worst things we used to do was a what's called a trust biopsy list. So we would do transrectal biopsies on men who had no anaesthetic, and they'd be lying in the fetal position, and we would take at least 6 samples from their prostate by putting an ultrasound probe into their rectum and firing away into their prostate. And they'd often be yelping, and it was a pretty distressing experience for them. And I wondered at the time, how is it that we can be doing this procedure in this day and age? So not only was it uncomfortable and distressing for patients, but it also had like a genuine risk of septicemia. Because even though we'd be giving the patients antibiotics as prophylaxis, you could still introduce bacteria that were just sitting in the rectum via the biopsy needle into their bloodstream. And we used to counsel them when we give informed consent. We'd say, okay, there's a risk that you might develop septicemia. If you're feeling feverish or getting uncontrollable shakes, i.e. rigors, then you need to go straight to hospital. And so that was really my initial sort of foray into research. And we did a bunch of research to show that if we went through the skin instead of through the rectum, we could avoid all of that altogether. It did mean a general anaesthetic at the time, although you can do it under local now as well. But the whole distress, pain, sepsis, gone pretty much. So that's been a huge change in my career, and it was great to be a part of that move in changing practice. And I mean, there are millions of prostate biopsies performed around the world. So that's been exciting, gratifying to see that going through the skin now is standard of care. But what we're looking at now is the changes that have occurred as a result of imaging in prostate cancer. So in those days, when we do a transrectal biopsy, it was because of an elevated PSA. So just a blood test, that was it. But of course, the PSA can be elevated for a bunch of different reasons. It may not be any cancer at all. Now we use MRI scanning to help us determine if a biopsy is needed at all. So non-invasive, which is fantastic. And, half the time the MRI shows no cancer, so they don't need a biopsy. But when it does show cancer, you can do a targeted biopsy, so it's even better. Then what we realize is that, okay, now we can see where the cancer is. Do we really need to take the whole prostate out if we find cancer? Do we really need to irradiate the entire prostate gland? Or could we use oncological principles that we use elsewhere where we just treat the tumor, not the whole organ? So, for example, if we have a small kidney cancer, we do a partial nephrectomy. We just take off the tumor and we preserve the rest of the kidney. Same with breast cancer, do a lumpectomy instead of a radical mastectomy. And so, we've been doing focal therapy where we just treat the tumor and we preserve the rest of the prostate. And the whole point is to maximize maintenance of function, because everybody knows that treatment of prostate cancer usually commonly results in erectile dysfunction and sometimes urinary incontinence, or if there's radiotherapy, can involve rectal symptoms as well. So these are significant impacts on men's quality of life. And if there's a way of minimizing that through using the modern imaging, why not try that? So we have been researching that for the last decade. We published recently in BJUI Compass on the oncological and functional results, so 2 papers of our study of focal therapy, which has been really exciting. So as I say, I've been doing that as part of my practice. It's very strict in terms of the criteria of which patients can actually have this type of treatment. So, for example, it's intermediate risk disease. It's not high-grade stuff. It's a unifocal deposit, so just one lesion that you can see on imaging. The biopsy confirms that. They're the patients that we're looking at. So we're not talking about replacing radical prostatectomy or radical treatment. We're talking about introducing an additional option for a subset of patients with localized prostate cancer. So that's been a real focus of my attention, and it aligns with my interest in minimizing harm to patients. I think still, because of our legacy practice of not having any imaging and therefore being radical with our treatment, that we're still overtreating a lot of patients. And unfortunately, I think in a lot of instances, there's still more harm than benefit being caused. And we've mitigated that enormously. And I've already talked about MRI avoiding unnecessary biopsies, but also when we find low-grade prostate cancers, we do active surveillance now. We don't treat those patients. And that's been a huge advance in our knowledge and our practice. The next step is for those intermediate risk patients is whether we can minimize treatment. We can still treat the cancer, but keep it literally minimally invasive with focal therapy, minimize the procedure itself, minimize the functional effects on their body, but still treat the cancer. And that's what we're looking at the moment. It's not a standard of care option as it stands right now in May 2026, but I'm confident that in 2 or 3 years, when we start to get long-term cancer outcomes coming through with the various studies being done, including our own, that it will become a recognised option for selected patients. I find that really exciting, because I think that would be not an incremental step, but a huge stride forward in terms of how we think about treating prostate cancer.
You talked about the burden just now on the health system, that we're not responding to prostate cancer in the way that we have to some other cancers, and that we can be. Some people think we overscreen. But I know there's a question of equality that you point to sometimes about how we're screening for prostate cancer. Can you speak to that a little bit, Jeremy?
Yeah, it's a great question. And I share the concern about overscreening. It really comes back to the dictum, first do no harm. That's something I feel strongly about, and it's why I'm keen on how we can mitigate risks. In the context of screening, the problem with not screening for prostate cancer is, what's the alternative? And the alternative is what's happening right now, and that's this sort of sporadic case finding, or opportunistic screening, as it's called. And that's where a patient and a GP might have a conversation about PSA. Now, if the GP happens to be interested in that area, then they might have a conversation. Or if the patient knows about PSA testing, then they might initiate the conversation. But that's as far as the obligation goes as things stand at the moment. And so the problem with that is that you're going to get a very uneven spread of testing across that band of men. And principally, we're talking about men aged 50 to 70. That's as a ballpark range, who can benefit from early detection of prostate cancer. So that's where the inequity comes in. But to the people who are arguing against overscreening, leading to overdiagnosis and overtreatment, they're absolutely right. That has happened in the past. I think what people need to catch up on now, though, is the current state of play, which, as I said a moment ago, includes triaging of who gets a biopsy with MRI. It includes active surveillance for anyone who's got low-grade prostate cancer. And now, and this is what I think is sort of another major piece of the jigsaw puzzle that needs to be put into place, is using focal therapy for the next step up. So it's not low-grade cancer, which doesn't need treatment at all. It's the next one up where you've got an early tumor. It's a higher grade, but it's not a bulky, aggressive tumor, which of course requires more intensive treatment. So I'm hoping that in the next few years, focal therapy will fit that piece of the puzzle in, and therefore keep the potential harms of overtreatment to a bare minimum. And therefore, if we do allow systematic screening across the population, let's say we had a national screening program, then you can minimize the inequity of access to early detection. We can prevent, not always, because no screening program is ever perfect, but you can minimize the number of men who are diagnosed upfront with metastatic prostate cancer. If we had a proper national screening program, that number wouldn't be zero, but I'm sure it would be much less than what we see at the moment. Now, thankfully, with PSA testing, those metastatic upfront diagnoses have dropped, but there's still inequity within that. And that's what I'm hoping a screening program will iron out.
Are you involved in the Urology Society still, or the college?
Not so much those bodies, but in the last 3 years, we've been attempting to update the PSA screening guidelines for Australia. So they're very outdated now. The last set of guidelines that came out more than 8-9 years ago now didn't include MRI at all, because we weren't there yet. We were starting to practice MRI, but it certainly wasn't sort of standard of care. It's been now standard of care for many years, but the old guidelines don't even mention it. So I was involved chairing the MRI working party as part of the current national guidelines. The national guidelines were not out yet, I should say that first up, but they should be coming out in the next few weeks or months, perhaps. It's been a very long process, but very rigorous scientific process, which is a good thing. Whilst it won't necessarily be a national screening program, I'm hoping that it's a step in that direction, whereby it becomes much more apparent that the harms of screening have been largely mitigated. There's still more work to do on that front, but we're making huge progress, and therefore the benefits are now outweighing the risks in order to argue in favour of not just some patients having access to early detection, but all eligible patients.
I think you've given us a really nice kind of example demonstrating how you're very involved in the kind of patient care, the one person kind of care, and systemic kind of change, the kind of looking from the helicopter and saying what's happening more globally, or what's happening across this issue more broadly. And this is where, we love specialists, because they've spent a long time, 20 plus years, in the research and seeing the iteration and the incremental change that's happening across the science. Science is ever evolving. So thank you for sharing that with us. My mind is definitely going to RACGP and ACRM and those other bodies that might be thinking about, well, how do we share this information now with our primary care practitioners, who are going to be meeting the patients in the first instance usually. I receive a letter from Breast Screen every 2 years or every 5 years or whatever it is, without the GP being involved really. The GP has the records, of course, but that's happening between Breast Screen and me. Do you imagine that sort of thing can happen for prostate cancer?
Yeah, well, exactly. I don't know exactly what format it would take, whether the GP remains involved or not. And that's obviously something that needs to be fully fleshed out. Whatever format it takes, it's a systematic format. It's not random. It's not sporadic, which is what it is at the moment. So yeah, that would be my hope, that we would have come a hell of a long way, and we can balance those genuine concerns about over-diagnosis and over-treatment that are real in prostate cancer with the genuine concerns about inequity in access to healthcare, which we've got right now.
In the interest of time, I'm going to switch tacks one more time.
Sure.
So I just wonder if you make any closing kind of comments or reflections that we might like to think about from your position of the director of department, or, just thinking about hospitals more broadly. I think the community and lots of countries are thinking about reducing hospital and having more hospital at home and these kinds of things. Any general comments that you'd like to share with us about what it's like to be leading a department working in public health, private health? What's important as a clinician leader in a hospital? What would you like people to understand about that?
So I guess the first thing to say is that, like any endeavor, it is all about the people. So yes, of course, you have to have competence in your discipline, but really it's about relationships. It's about trust, and they are the absolute priorities in any sort of leadership. I mean, obviously this goes way beyond medicine. It's just across the human race generally. It couldn't be more important. We're also faced with this brand new behemoth of a challenge, which is AI. I say challenge, it's also an incredible opportunity. Maybe I'm a bit pessimistic in that when we've had new technologies come on board, we play with them. We don't have the luxury of discernment when it comes on. So I'm thinking mainly of smartphones, social media, for example. And so it can turn into a cesspit like Twitter is now. And that's a great shame, because initially Twitter was incredible, had amazing utility, could, galvanize people together, be more democratic and all that sort of stuff. But it can then bring out the lesser angels of our nature. And I'm worried that if we don't use AI very wisely and get regulation happening sooner rather than later, then those nefarious aspects of our own nature will come out in AI, and it will be much more about maximizing dollar and not really caring about human relationships. So we've got to be extremely careful about how we manage that. To be honest, I think that is by far the biggest issue facing us right now. And there's incredible opportunities. If we think about AI as being pattern recognition gurus, obviously there's a huge amount of that happens in medicine. All of diagnosis is pattern recognition, whether it's clinical diagnosis, radiological, histological. Me talking to a patient in the consulting room with various symptoms drawn out, blood test results, and put the picture together, and it's usually pretty straightforward as to what's going on. All of that stuff lends itself to AI. What's interesting is how people are turning to AI for empathy as well. That's really interesting, and that's a whole other topic of conversation. But I thought going to be the sort of last bastion where human-to-human contact would be the most successful. But at the moment, at least, it seems that many people are finding other humans too hard, and AI is actually a softer ear, if you like.
Yeah, AI is affirming. That's part of its modus operandi.
Mm.
Right. We could go on all day, Jeremy. It's just a
Good.
delight talking to you, and I'm very, very grateful for your time. Is there anything that in our conversation you want to go back to or reflect on to wrap any loose ends up? Is there anything that you felt like you wanted to point to as we finish our conversation?
There's probably just one more thing, Sharee. We've talked a bit about empathy, vulnerability, especially in the current political zeitgeist. You've got people like Elon Musk saying that empathy is weakness. And I think that's tragic coming from somebody who has millions of followers online, because I think it's the complete opposite. Empathy is really the greatest human strength. It's how you use it is what's important. Like any quality or asset or trait that's positive, there could be a dark side to it as well, a shadow side. And if we over-index in one way or another, we're probably going to get it wrong. So it's about finding that balance. We talked a bit before about emotional empathy versus cognitive empathy. For me, that's something that makes sense as a practitioner. I think Empathy is absolutely critical, but you've got to figure out what's going to work for you in terms of maintaining your humanness as a practitioner, but also your energy and sustainability. Cognitive empathy is something that seems to work for me. So that's something I want to mention. Also, that, and this might sound a bit Orwellian, but vulnerability is strength. It's not weakness to demonstrate your vulnerability, and again, within context, in a trusted environment with the right people, where it's going to be useful, not as a woe is me, I'm a victim mentality at all, in a manner of sharing, yeah, I'm human, and sometimes I struggle and sometimes I need help. And as a helper or a carer, as we are in medicine, that's okay too.
Thank you very much for beautiful, wise words to close our conversation. And I look forward to sharing this conversation with our listeners. Thank you, Jeremy.
Can I say one more thing?
Yes, please.
I've missed out on one other thing that's really important to me, and that's humour. So I've been pretty earnest about all the things we've been talking about, and all of that is appropriate, but we've also got to lighten up a little bit. So one of my values, and that's worth talking about as well, is figure out what your true values really are, and then try and live your life according to them, make decisions according to them. And what I've figured out is one of them is humour, which is based on the premise that the fact that we are these conscious beings in an infinite universe is utterly absurd. And so if something's absurd, we should laugh. And that's a guiding value for me as well. So try and remember, in what is otherwise a very serious business of medicine, where some of your decisions are potentially life and death, at the right times, to remember a bit of lightness.
I'm resisting the urge to ask you for a dad joke.
Oh, gosh. I dropped a whole lot of dad jokes when we were having dinner with my girls last night. The eye rolling that I got was enough to prevent me from telling any right now. But it's really just to remember to laugh and try and crack jokes with each other in the clinic, in the hospital, not so much with your patients because they may not be ready for it at the time, but certainly gallows humour, which is obviously a bit of a standard in medicine, is there for a reason. Yeah. And it's important that we use that humour.
Exactly. Thank you very much for beautiful, wise words to close our conversation. And I look forward to sharing this conversation with our listeners. Thank you, Jeremy. The content in this podcast is not intended to constitute or be a substitute for professional medical or psychological advice, diagnosis, or treatment. Always seek the advice of your doctor or other qualified healthcare professional. This podcast represents the views of the hosts and guests and do not necessarily reflect those of any entity we work with or for.